On behalf of WHO and on my own behalf, I want to thank ICOP Main Commission and in particular Committee 3 for giving me this opportunity. I will address the topic of justification of medical exposures, and I want to start maybe here. I want to start just mentioning very quickly that we are very close to days that will be celebrated very soon and very relevant for this session. And it's the first International Day of Medical Physics, the International Day of Radiology, and the World Radiography Day on 7 and 8 November. And it's very relevant for this topic because these dates were the dates when Marie Curie was born. Also, 7 November was the day when Marie Curie received the second Nobel Prize for her contributions to radioactivity knowledge. And the 8th November, the day when Wilhelm Röntgen discovered the X-rays. So I wanted just to remind that. And in this context, since the discovery of X-rays, the use of radiation in healthcare increased, expanded, and in particular in the last decade. And the benefits gain recognition, and therefore I will not talk about benefits because this was already mentioned, but this is the main topic that we want to put ahead. But still, the modern technology being safer, the inappropriate or the incorrect handling may result in unnecessary or unintended radiation exposures. The international community and in particular was the IAEA organizing an international conference on radiation protection in medicine last year in December in Bonn. WHO was co-sponsoring this conference. And the main outcome of this conference was the so-called Bonn Call for Action. This was published in July as a joint statement of IAEA and WHO. I will not go for the 10 actions, but just to point out that the first action identified to improve radiation protection in the next decade was the enhancing of implementation of justification, and the last, I will just refer very shortly at the end, was strengthening the implementation of the international safety standards, the basic safety standards, and this is also very much linked to implementation of justification. And this first action of the Bonn Call for Action is also very much detailed. We will not read all these sub-points, but just to show that the action considers all the components: awareness raising, education training, referral guidelines, audit, that I will mention now very quickly. When we talk about appropriateness in imaging, we could say that's a message: best test first. When choosing the procedure, the risk-benefit is the most important, the first step. But even if the benefit outweighs the risk, the procedure may be unnecessary if there are other options, if the clinical evaluation could answer the response, or if an accurate diagnostic could be achieved by using a procedure that does not deliver radiation exposure to ionizing radiation. And other parameters have to be also considered. So the benefit will outweigh the risks if the procedure is appropriate, prescribed, and also properly performed. So we could just say, do the right procedure and also do the procedure right. And this is basically justification and optimization. But I'm focusing now in imaging, although justification, of course, also include therapeutic procedures, because here is where we have the main issues. And I want to mention here that there is a link between justification and optimization, and the precedent speaker gave an excellent example, how a CT could be justified in a PET CT, but if you don't optimize properly, then the final protection of the patient is not achieved. So this is something that I wanted to bring here to consider both as a critical for protection of patients. What are we talking about when we mention referral guidelines? Let's talk about what is evidence-based medicine. Evidence-based medicine is the integration of the best scientific evidence with the individual clinical expertise. It's not just scientific evidence. The referral guidelines are decision support tools that are based on the evidence and that will assist the medical practitioners to make their own decisions. And in particular in medical imaging, when a procedure is justified, when the outcome of the procedure, either positive or negative, will have some implication in the management of the patient or will strengthen the confidence on the diagnosis. So this is why I want to emphasize that our support tools for evidence-based medicine are not rules. And these are examples that were already mentioned, so I just quickly to show to you that these are the American College of Radiology appropriateness criteria, these are the Royal College of Radiology referral guidelines, but all of them, the entry point is a clinical condition and then the different procedures and their appropriateness or grade of recommendation. There are many reasons for unnecessary or unjustified exposures. We can add even more, much more. I will just focus now on one of these because it somehow is gathering different causes, and it's the defensive medicine. Defensive medicine is a strong driving force for overuse of radiation, especially imaging. In the United States, more than 80% of doctors acknowledge having practiced defensive medicine in their careers, and quite often imaging is one of the ways they applied this because of concerns about malpractice litigation based on advertisement, marketing, pressure from patients, pressure from colleagues. So we have to tackle this. And it was demonstrated that since referral guidelines are really not compulsory, are advisory, and the physician may deviate for the guideline, but the physician has to have a very good reason for doing that. It was proved that just in a voluntary basis have not been implemented properly in the world. So computerized order entry systems that allow the integration of these decision systems in the daily work of the doctors have proven being effective to increase the implementation. And one of the main reasons why referral guidelines are not implemented is because they are not available at the point of care. And we also learn from experience that the big book, bulky handbooks or manuals or even hard copies of referral guidelines quite often are not used by the doctors. Therefore, this clinical decision support are really, we can see this as the tool to improve implementation in the future. And it's not just the content, which is of course essential, but also the format and the media. And this could be adapted to different clinical settings. And in those settings where internet access is not available, mobile phones may be available, and we can use even mobile phones to make the guidelines available at the point of care. And it was demonstrated by different studies like this one that once you introduce a decision support system integrated in the order entry system for doctors, the use of CT in this hospital was decreased, which is, well, is one indicator. We can discuss that it's not just a direct indicator, but it's one indicator that most probably the reduction was due to the use of the referral guidelines. Other key point is the involvement of stakeholders and end users in the process of development of the guidelines and implementation, and in the monitoring of the use, and in the evaluation of the impact. And these approaches has to be tailored regionally and locally. There are many stakeholders. We have no time to go around all of them, but this is essential to identify all the potential stakeholders, directly or indirectly related to the guidelines, also to map their interests and how they can be positioned in face of the implementation of referral guidelines, because not all of them will be supporters. Some of them may be blockers, and we have to address them. Two main stakeholders are the healthcare professionals and the referrers that we have to put as a priority, and I want to bring here also the other key stakeholders, the patients. The patient associations are already engaged, and you can see here how they are reflected. This is the Patient for Patient Safety Network. They are already engaged even in the bone call for action. Communication with patients is an essential component, and we need to improve the dialogue, providing tools to improve communication. To finalize, I focus very quickly on the BSS, how BSS addressed the justification, and this is the paradigm that was mentioned several times this week. I want to show that there is still a gap between the paradigm and the BSS and what happens in the real world of medicine. How to bridge this gap? How to explain this complexity, and I will move now quickly, the complexity of the changes in the approaches of justification that ICRP has done in the last years, and that was also reflected in the BSS with this approach of the 3 levels of justification, and how to explain to the doctors what does it means, the justification in the level 2, which is really what is reflected in the referral guidelines, the justification of a procedure, and how this is different from the level 3 of justification, which is the justification of the individual procedure for the individual patient. And there are roles and responsibilities for 2 players here, radiological medical practitioners and referring medical practitioner. And there another new issue that was also introduced in the BSS is the issue of the individual health assessment of asymptomatic individuals. And it's also very well indicated there that this needs a special justification with interaction between the 2 practitioners and the information to the patient. And other specific justification requirements for volunteers in research programs, female patients in reproductive capacity, breastfeeding women, and the need for audits. So, to finish, what we need from ICRP to improve justification of medical exposure, we need input for the harnessing of a global research agenda in radiation protection of medical exposures. We mentioned several topics today, but I think one critical was the new data about children risks, and really ICRP could really help looking at these new findings just very soon published by UNSCARE and see which could be the implications in radiation protection in medicine, if any, to provide a framework for justification of medical exposures and also including asymptomatic individuals, to provide materials, information products to improve the communication with health professionals and with patients, and also to contribute to the development of these tools to bridge this gap between the community of radiation protection and the doctors. I think that ICRP has a lot to contribute. All of you, all of us have something to do to put this small piece of the puzzle to improve radiation protection of patients. Thank you very much.